Welcome, everyone. Today we're going to tackle a really serious condition, malignant otitis externa. Now let's be clear from the get-go, this is not your typical swimmer's ear. We're talking about an aggressive, flesh-eating infection that starts in the ear canal but can chew its way right into the skull base. It is a true otologic emergency.
So here's our roadmap. We'll start by defining what makes this a necrotizing emergency. Then we'll play detective and identify the microbial culprits. After that, we'll cover treatment, prevention, and the pretty severe complications. And we'll wrap it all up by walking through a couple of clinical cases to see this in action.
Okay, first things first. Let's really nail down what we mean when we call this a necrotizing emergency.
The key word here, the thing that changes the entire game, is invasion. The infection doesn't just stay in the skin of the ear canal. It punches through, getting into the cartilage, the marrow, and the bone itself. This progression into osteomyelitis, that's the pathognomonic feature. It's what separates this beast from a simple, superficial ear infection.
So, who do we need to worry about most? Well, this disease is an opportunist. It thrives when the body's defenses are down. The classic patient profile is someone with poorly controlled diabetes. The high sugar messes with small blood vessels and hobbles the immune cells. Similarly, HIV compromises the immune system, and prior radiation therapy can damage local tissue, basically rolling out the welcome mat for an invasive infection. The patient's history is everything.
All right, let's move on to identifying our perp. You can't win the fight if you don't know who you're fighting, and that is absolutely the cornerstone of managing this disease. Here's your big clinical red flag. If you've been treating what looks like a standard otitis externa with topical drops for 3 weeks and it's not getting better, you have to stop. It's time to think differently. This is the point where you have to suspect an invasive process, and that means getting deep tissue samples, not just a superficial swab, for both bacterial and fungal cultures.
Now, while everyone's first thought is Pseudomonas, and for good reason, you absolutely cannot forget about fungi in these tough, refractory cases. Look at these numbers. Aspergillus is the big one, showing up in 60 to 90% of these complicated fungal cases. Candida makes up most of the rest. That is a huge piece of the pie you can't afford to ignore.
You can actually get some pretty good clues just by looking in the ear with an otoscope. It's not diagnostic, but it's suggestive. Candida often looks like a white, sort of cottage cheese-like gunk. Aspergillus niger, on the other hand, can have this really classic look, a moist, felt-like plug with little black dots sprinkled all over it, which are actually the fungal spores.
You know, treating these fungi is a long, arduous process. So before we dive into that, just a quick moment of levity. A microbiologist walks up to a bar, but the bartender stops him and says, "Sorry, we don't serve your kind in here." And the microbiologist just looks at him and says, "Why not? I'm a fungi."
Okay, all right, all jokes aside, let's talk about the heavy lifting, the therapeutic strategies. This requires an aggressive, all-out assault, often for a very long time.
So when you suspect invasive disease, you can't just wait for the culture results to come back. You have to act. That means starting empiric, systemic therapy right away. You need to cover your bases, hitting the most likely bacterial culprits like Pseudomonas and probably Staph aureus, depending on the clinical picture.
Now, for invasive fungal disease, especially Aspergillus, it's a two-pronged attack. Pills alone are not going to cut it. You have to pair those long-term systemic antifungals with aggressive surgical debridement. And I mean aggressive. A surgeon has to go in there and physically remove all the dead infected tissue and bone to give the medicine a fighting chance. After hearing about treatments like that, you can see why prevention is so important. So let's talk about patient counseling and how we can try to avoid this whole mess in the first place.
This all comes down to respecting the ear's natural defenses. You have to tell your patients to stop putting things in their ears. No cotton swabs, no keys, nothing. That just creates tiny tears in the skin. Also, earwax is not the enemy. It's protective. So aggressive cleaning is out. And finally, especially during an active infection, you have to keep the ear dry. Moisture is a microbe's best friend.
So, let's talk about why this disease earns its name. The term malignant here doesn't mean cancer. It refers to its relentless, aggressive course and the potential for some truly devastating, life-threatening complications.
This infection does not respect boundaries. It can spread through natural weak points in the bone, causing osteomyelitis of the temporal bone, which can then lead to cranial nerve palsies. The facial nerve is the most common casualty. But the most feared complication, the absolute worst-case scenario, is when it spreads to the base of the skull and into the brain. That carries an incredibly high mortality rate.
Okay, theory is one thing. Let's put this knowledge to the test and see how it applies in the real world with a couple of quick case vignettes.
So picture this, a 70-year-old man, his diabetes is a mess, and he has this horrible, deep-seated ear pain that just won't quit, even with antibiotic drops. What's screaming out at you from that history? And what is the one thing you absolutely must do next?
If your brain immediately screamed malignant otitis externa, you are absolutely right. The patient profile, the severe pain, the failure of topical therapy, it's the classic triad. And the critical next step is to get a deep tissue biopsy for culture and pathology, not a swab. You need to prove invasion and find out exactly what you're fighting so you can start the right systemic therapy.
All right, case number 2. You've got a confirmed diagnosis of invasive Aspergillus otitis. We already know that the treatment plan involves both surgery and systemic antifungals. But my question is, why? Why can't we just rely on our powerful antifungal drugs to do the job? Why is surgery non-negotiable?
And the reason comes down to pathophysiology. Aspergillus is nasty. It creates this mass of dead necrotic tissue and bone that has no blood supply. You can pump a patient full of the best antifungal drugs in the world, but if the medicine can't get to the bug because there are no blood vessels, it's useless. So surgery isn't just helpful, it's essential. You have to physically remove that dead fortress of fungal infection to let the drugs get to the living tissue margins and stop the spread.
And this brings us to one final critical thought. When you have a really severe or recurrent case, especially in a patient who doesn't have the classic risk factors like diabetes, you have to start thinking bigger. We have to look beyond just the pathogen and ask, what's wrong with the host? Could there be some subtle underlying immune defect, maybe a neutrophil function or a cytokine pathway? Investigating these patient-specific factors is really the next frontier in managing this disease. It's about moving from just treating an infection to truly managing the patient as a whole.